Respected President ISA Kerala State, Dr. Binal Isaac Matthew, esteemed faculty leads of today's sessions, distinguished members of ISA Kerala, dear colleagues, residents, and participants joining us from across the state and beyond. It's indeed my proud privilege to welcome each one of you to episode 4 of Anesthesia Connect. Now, this platform was created with a simple intention, that is to bring our fraternity closer, to share knowledge in a practical and engaging manner, and to strengthen the scientific conversations that define the spirit of ISA Kerala. Seeing the enthusiasm with which every episode is received, it reminds us that lifelong learning is truly the heartbeat of our specialty. Now, today's program brings together themes that lie at the core of safe and modern anesthesia practice. Now, we begin with the exploration of risk scores in anesthesia. Tools such as AnaesthesiaCONNECT and Stop Bank questionnaire may appear like numbers on paper, but in the hands of the anesthesiologist, they become instruments of clarity and prediction. We then move on to communication skills in anesthesia, an area that is often underestimated despite being the foundation on which trust is built. Now, whether we convey risk, reassure a family, or coordinate with our surgical colleagues, the way we communicate, it shapes outcomes as much as any drug that we administer. Now, regional blocks is the next episode, which continues to inspire innovation in our practice. And skill-based teaching, it remains one of the strengths of our community. And to learn tips and tricks, or rather the techniques, from those who have mastered it is an opportunity we all value. And this will be followed by the Anesthesia Chronicles, which will take us on a different journey altogether into stories, forgotten notes, and real-life events that have shaped our discipline. Now, every specialty, it carries a legacy, and revisiting that legacy enriches our understanding of the present. Now, to add some friendly competition and fun, we also have the ISA Kahoot quiz. I encourage everyone, be it a first-year postgraduate student or to a senior professor, to participate wholeheartedly. These interactive moments strengthen the camaraderie that makes our association vibrant. Now, as Secretary of ISA Kerala State Chapter, I thank every faculty member who has prepared for today's sessions, our webinar coordinators, the whole team comprising of Dr. Sanish, Dr. Sajesh Ji, and Dr. Rajesh MC for making this platform seamless, and finally all of you for your commitment for ongoing education. Now, your presence here today, especially on a weekend evening, speaks of your dedication to excellence. I wish each one of you a meaningful and enjoyable learning experience. Over to our President, Dr. Binal Isaac Matthew.
Thank you, Dr. Vijesh, for the kind introduction. Good evening, my dear friends and senior colleagues. Warm welcome to the 4th session of Anesthesia Connect and the 3rd episode of the magazine edition. Your continued participation every Saturday truly motivates us and strengthens this academic initiative. Today, we continue our journey through thoughtfully curated topics that bring together knowledge, experience, and new insights in anesthesia. My sincere appreciation to our speakers, our moderators, Dr. Sajesh, Dr. Sanish PJ, Dr. Vijesh Venugopal, and the organizing team for their dedication. I also encourage all our delegates to take part ISA Kerala Kahoot quiz during today's session. Our quiz masters have prepared engaging questions, and there are exciting cash prizes are waiting for you. So do participate and make the session even more live. So with this, I declare today's session open. So over to Dr. Ashumatai for the session. Thank you.
Welcome to the next edition of Risk Scripts. Today we're going to be looking at scores that predict pulmonary complications. So we'll be looking at two main scores, that is the AnaesthesiaCONNECT score and the Stop Bank score. The AnaesthesiaCONNECT score helps us to identify which patients are at an increased risk of postoperative pulmonary complications based on the age, the saturation, the type of surgery, and the clinical history. For airway and sleep-related concerns, we have the Stop Bank score, which quickly screens for obstructive sleep apnea, which is a major contributor to both pre- and post-operative respiratory instability. Now, together, these scores help us to move from guesswork to targeted planning and better oxygenation strategies, and thereby ensuring smooth recovery. Over to Dr. Anukrupa, Assistant Professor at Believers Church Medical College Hospital, to explain this in more detail. Now, before we start, a quick question for you in the chat box. Do you know which are those small details that are pushing your patient's ARISCAT risk up? Do put in your answers as we discuss this important topic. Over to Dr. Anu.
Hello and welcome to our next session in the Risk Script series. We will be discussing about preoperative pulmonary risk stratification. Now, why do we need preoperative pulmonary risk assessment? It helps us identify patients who are at a high risk of developing post-operative pulmonary complication. Having identified these patients after a thorough medical history and physical examination, and after having done the relevant laboratory and radiological investigations, it helps us mitigate any further risks that could complicate their perioperative period, such as in patients with COPD and asthma. We could tailor the therapy for optimal outcomes. We could address exacerbations with corticosteroids or antibiotics and delay surgery if required. If the patient is an active smoker, we could encourage them to quit at least 8 weeks prior to surgery. If the patient is having active respiratory tract infection, we could postpone an elective surgery by 6 weeks for the infection to resolve and probably initiate them on antibiotics and supportive management as required. If the patient is planned for a major abdominal surgery or a thoracic surgery, we could initiate them on chest physiotherapy or incentive spirometry and breathing exercises, which could improve their postoperative outcome. Now, having identified these patients and addressed their concerns, and having stratified them as low, moderate, or high risk patients for developing postoperative pulmonary complications, it helps us in the decision making process, which involves the surgeons, the patients, and their families. But it also helps us to make a specific, well designed care plan for their perioperative period. Now, what are postoperative pulmonary complications? Unfortunately, we do not have a universal definition for postoperative pulmonary complications, but we do have international working bodies that have come together with the aim of setting standardized endpoints for perioperative and anesthetic care trials. So one such body is the STEP Compact. STEP stands for Standardized Endpoints in Perioperative Medicine, and Compact stands for Core Outcome Measured in Perioperative and Anesthetic Care. So they have suggested that diseases sharing the similar pathophysiological mechanisms should be combined into a composite postoperative pulmonary complication outcome, and this would include atelectasis, pneumonia, ARDS, and pulmonary aspiration. Now we have various risk prediction models to assess the postoperative perioperative pulmonary status of the patient. But the common named models are Arizula, Gupta, ARISCAT, and the American College of Surgeons NSQIP Universal Calculator. Of the many scores, the most widely used is the ARISCAT score. Now, ARISCAT stands for to assess respiratory risk in surgical patients in Catalonia. Catalonia being a place in Spain. But this has had the most validation cohorts, and it has been performed across various cohorts in various populations and has come across as an effective tool for guiding patient care. Hence, has been used widely. Now, having looked at this, we have a case of a 68-year-old male who's coming for emergency laparotomy for suspected bowel obstruction. Now, the relevant history that we have is that he is a known case of severe COPD on inhalers. He has a BMI of 32 kilogram per meter square. He is a smoker with a history of 40 pack years. He is a known case of hypertension, optimized on medication. He has no known history of OSA, but there is history of snoring. On examination, we found out that his preoperative saturation is 93% on room air. Now, after a detailed preoperative assessment, we have concluded that this patient is ASA status 3E, E being the emergent nature of the procedure. Now, if we were to apply risk scores into this scenario, let us see what new insights we would gain. So, if we were to look at the AnaesthesiaCONNECT scoring, this patient is between 51 to 80 years. His preoperative saturation is 93%. There is no history of recent respiratory tract infection, and his hemoglobin preoperatively is 12 gram per deciliter. It is going to be a midline incision, so it is an upper abdominal incision. The duration of surgery would be anywhere between 2 to 3 hours, and this is an emergency procedure. So we have 50 points on the AnaesthesiaCONNECT score. We will come about to how to interpret this. Meanwhile, this patient also has a history of snoring, and he's also obese. We would also like to assess for the severity or the probability of having obstructive sleep apnea. So we would try to apply the stop bank score. Now, on applying the stop bank score, yes, he does snore loudly. He does not feel tired or fatigued, or there is no daytime sleepiness. There is no witnessed apneic episodes during sleep, but he does have hypertension on medication. His BMI is less than 35 kg per meter square. His age is more than 50. His neck circumference is less than 40 centimeters, and he is a male patient. So we have a stop bank score of 4. So now if we were to interpret this, we have an AnaesthesiaCONNECT score of more than 45, which puts him in the high risk group. That would translate to him having a 42.1% chance of developing postoperative pulmonary complications. And his stop bank score is 4, which is greater than 3, which suggests that he is at a high risk of having obstructive sleep apnea. Now, given that he has not been diagnosed before, he's also not been optimized, this would increase his chances of postoperative ventilation. We also do have some limitations that come with the pulmonary risk scoring. Because these risk scorings are varied, there is lack of uniformity in the definition of postoperative pulmonary complications. This increases the heterogeneity and limits us from generalizing these models. There is inconsistent accuracy in predicting morbidities, and it may not account for all factors leading to postoperative pulmonary complications. To summarize, all is not bad if used prudently. It replaces subjective judgment with objective quantifiable data. It helps us tailor our perioperative management. Using the risk scores will improve our patient outcomes by reducing their incidence and severity of postoperative pulmonary complications, and it will help us with informed consent and shared decision making. It will also allow for appropriate resource allocation, such as an ICU backup or improving targeted therapies. I hope this has shed some light on preoperative pulmonary risk stratification. Thank you.
Today we saw the use of tools like the AnaesthesiaCONNECT and the stop bank, which helps us catch pulmonary risk early, plan smarter, and keep surprises out of the postoperative period. When we measure better, we manage better. In our next episode, coming up next week, we move from the operating room to the recovery path, exploring postoperative risk prediction with the surgical APGAR score, the SAS, and the POSM score. And we will see how these scores can help us see complications before they actually happen. Do join us next week for our last episode of Risk Scripts. Thank you.
Good evening. Welcome back to the third session of medical communication. Today, we are going to learn about non-verbal communication. The communication can be of different types: spoken communication, written communication, and using symbols. The spoken communication has two components: verbal component and non-verbal component, and 70 to 80% is non-verbal. So mastering in non-verbal communication is essential for developing communication skills. What are the different components of non-verbal communication? Facial expression, eye contact, body position, body posture, distance between individuals, and therapeutic touch. Facial expression. The expression of your face is conveying so many things to the listener. Look at this facial expression. He's very indifferent. He's very unfriendly. Look at him. He's very angry. So these types of facial expression are not acceptable when you talk or when you communicate with your patient. The most ideal will be like this. So if you have empathy in your mind, of course, you will be able to modify your facial expression. Just look at the patient's eyes and just smile. So this facial expression will make the patient comfortable. The second point is eye contact. What are the benefits of maintaining eye contact? Patient is likely to remember a face. Patient is likely to remember what you said long after the conversation has ended. Likely to believe what you are saying. And patient will perceive you as more confident and intelligent, and will be better able to read and mirror other non-verbal cues from the doctor. So if you are able to look at the patient's eyes, that means you are confident. Now I will give you some tips for making eye contact. Establish eye contact before you start conversation. First you look at the patient's eyes and then start speaking, rather than speaking and then looking. This is the better way. Establish eye contact. Look into the eyes and then start speaking. Look for about 4 to 5 seconds. You'll be able to hold eye contact for about 4 to 5 seconds, because more than 5 seconds, it's very difficult to look at somebody's eyes, because it is very uncomfortable for the patient as well as for the doctor. But don't stare. I said it's very difficult to look at somebody's eyes for more than 5 seconds. So there's something called a triangle technique. Imagine an inverted triangle connecting the eyes and mouth, okay, like this. Now, once you finish looking at the patient's eyes, that means direct eye contact. Now you can look anywhere inside this triangle, okay. So it is less comfortable for you as well as for your patient. And after 5 seconds after you look into this area, again you can go back and look into the patient's eyes, okay. Now there is something called 50-70 rule. You have to maintain eye contact 50% of the time when you speak and 70% of time when you listen. That means more eye contact during listening. Look away slowly. What does it mean? So when you look away, you have an eye contact and you'll be looking away, and always do it in a slow manner. Looking away too quickly, that is darting your eyes, can make you appear nervous and shy. Look at this picture. This man has made eye contact. Now he is looking away, isn't it? Now this looking away should be in a slow manner. If it is too fast, it is darting. Okay. So that is not acceptable. That is not a good method of, eye contact. You should look away slowly rather than look away fast. A position. What do you mean by position? Look at this picture. Here, the doctor and patient both are standing. The problem is body is not relaxed. When you stand, your body is not relaxed. At the same time, mind is tense. So conversation is going to be hasty. Of course, since he is standing, patient may not be listening to you properly. And since you are standing, you are also impatient. So you may not be able to convey the message. Look at this picture. Here the doctor is sitting, the patient or caregiver, in either way, is standing. So here, of course, doctor is relaxed physically. But what about patient? Patient is not relaxed physically because the patient is standing. So problem is again, patient may be impatient and may not listen to you properly. So the ideal, the most appropriate position is like this. You can say both doctor and patient are sitting. Both are relaxed physically. There will not be any impatience for the speaker as well as for the listener. Another point you have to notice is there is no physical barrier or table between the patient and the doctor because patient is not sitting across the table. Now, posture. What do you mean by body posture? Look at this picture. The doctor is sitting, but not sitting straight. He's leaning towards the patient. And look at the arms. The arms are open, not in a crossed manner. Open arms. So what does it mean? And this is called as open body language. Okay. And this indicates openness and caring. Look at this picture. Here, the arms are held in a crossed position. Okay. And this is called a closed body posture. I will show some more examples of closed body postures. Say sitting with crossed legs, crossed arms, not acceptable. Sitting with, arms on hips, not acceptable. The arms kept on the back, not acceptable. The first posture is a defensive posture, while the other two are offensive. The distance between persons or individuals. This is a very important point you have to keep in mind when you talk to somebody. Say, these distances are classified in different ways: intimate distance, personal distance, social distance, public distance. Intimate distance is 45 centimeter, which is allowable only for spouse, children, and very close friends. And personal distance is about, you can say about 1 meter. And for a doctor-patient conversation, this is the ideal distance. Too close or too far are not appropriate for effective communication. Now moving on to the last component, therapeutic touch. Look at this picture. The doctor is gently touching on the hands of the patient. Okay. This is very important when there is an emotional outburst. Okay, especially when you convey bad news. And of course, this therapeutic touch application depends upon the gender as well as on cultural practices. Look at this picture. What is your comment? Doctor is sitting. Doctor is leaning forwards. And the doctor is also using that therapeutic touch, isn't it? In what way this therapeutic touch is different from the previous one? He is touching on the shoulders. And this is called a paternalistic touch. See, paternal touch conveys a message that, see, I am superior to you. Okay. So, the better way of application of therapeutic touch is like this. Okay. Touching the hands. Now, we discussed about the various components of nonverbal communication, a good facial expression, a good eye contact, appropriate body position, appropriate body posture, appropriate distance between the doctor and the patient, and appropriate application of therapeutics makes the communication better. Thank you very much. And next week, we'll be dealing about various components of verbal communication as well, communicating the bad news.
Good evening, my dear friends. Welcome back to Blockbuster. Here we try to debunk the myths related to regional anesthesia and peripheral nerve blocks. Welcome to today's episode. Here we try to debunk another myth, that is the ultrasound is always superior to nerve stimulation for all blocks. But reality is the evidence shows a more nuanced picture with an optimal approach depending on the specific block and clinical context. We have a paresthesia technique, nerve stimulator technique, and newer ultrasound guided nerve blocks. The peculiarity of the ultrasound guided regional anesthesia is that we should have three things for a successful nerve block. The first one is there should be a nerve. Second, your needle should reach near the nerve and not into the nerve. And third thing, your local anesthetic should spread around the nerve. All these three possibilities happens only with the presence of an ultrasound guided regional anesthesia technique. With nerve stimulator, with almost 100% precision, we can locate the nerve, but once we started injecting the local anesthetic, we lose all the control over the drug spread. Further drug spread is not guaranteed. But here in ultrasound, we can see the drug spread also. So, ultrasound has a lot of advantages. It has got a direct visualization, can see the nerves, needles, drug spread, everything. Increased success rate and more reliable block quality, reduced risk of vascular puncture and other complications, decreased volume of local anesthetic is required, low risk for the inadvertent intraneural and intravascular injection, short procedure time, and improved patient satisfaction. It has got a learning curve for the ultrasound is steeper, but leads to higher final success rates once you attained a good experience with ultrasound guided nerve blocks. But it has got some problems. Needle visualization, especially in the deeper blocks, where the needle angle is more than 60, around from 40 to 60, we can see the needle trajectory clearly, but beyond that 60-degree, it's very difficult to visualize the needle. And of course, most of the time we need outer plane technique for the needle placement and deposition of the local anesthetic because of the anatomical peculiarities of deeper blocks. And a portable ultrasound machine, it has got a limitation on identifying the perineurium. The resolution of the portable ultrasound machine is not yet able to distinguish the perineurium. So the perineurium injury cannot be avoided. The problem is that in most of our ultrasound, in our clinical practice is a portable ultrasound. So it has got a limited precision on identifying the deeper structures of the nerves. And poor quality image that they are also depending upon the different types of ultrasound. And scanning skill of the operator also is a major concern. So for the best practice, use dual guidance, that is ultrasound plus nerve stimulator. especially in deeper blocks like lumbar plexus, deep sciatic, that's the sacral plexus and all, and in patients with obese patients and pediatric patients and anatomically distorted patients with anatomical distorted and all. And another very important indication is an old age patients. Here we may face a difficulty in visualizing the nerve. The more of the connective tissue content there in the neural tissues, muscles and fascia and all because of the aging process. So very difficult to differentiate the neural structure there. And of course the dual technique is very useful for the training purpose. And ultrasound combined with other techniques is that newer modalities coming up. It's only in the research line, it's not at all available in the clinical practice. Some of them are the magnetic navigation in around ultrasonics launch and ultrasonic picture navigation system based on the magnetic position and which enable to puncture at any angle and monitor the position of the needle tip in a real time. And Philips also launched a three-dimensional ultrasound navigation, and magnetic position is a real-time position technique using a non-visual state based on the ability of the magnetic field to penetrate unshielded objects and all. Then the pressure guidances. Pressure guidance is a recent study attempted in patients with video-assisted thoracic surgeries done a paravertebral block using this technique. Here we can identify the negative pressure once they penetrate the superior costotransverse ligament in paravertebral blocks. And next one is an video visualization guidance. Here we can see the ultrasonic guided nerve blocks is performed under the direct video visualization. Then we have an electromyography guidance, especially in QL block. There's one study in QL block and all. We can locate the muscles where exactly the muscle twitching and with the help of electromyography and all. Then optical coherence tomography guidance is an ultrasound based optical stimulation technique that provides micron level imaging resolutions, and this is an order of magnitude greater than the ultrasound. Then we have an AA guidance that is mainly for the training and all. Then we can have a image fusion guidance. Here we collaborate the CT, MRI and all of them, but these are all under research only. So for the time being, we have for the deeper blocks, for the successful deeper blocks, we have ultrasound. We have to combine the ultrasound with nerve stimulation and so if you are using it as a sole anesthetic technique. Here is on old lady with fracture hip, a fracture trochanter, planning to do PFN-E2, and the patient is contraindicated for the spinal because of there is an intracranial lesion and his spinal is contraindicated there. And so here what we are trying to do is do a sacral plexus block, and with around 20 ml of 0.5 ropivacaine is given with the sacral plexus block, and looking for the stimulation of the plantar flexion there. And then we done a lumbar plexus with around 15 to 20 ml with 0.5 ropivacaine there, with added dexamethasone also. This patient we had given dexmedetomidine infusion. Was given total around 1.5 hours surgery. We gave only around maximum of 30 to 40 minutes. No other medications. Purely done under regional anesthesia. This is the power of regional anesthesia where the spinal is contraindicated. So to conclude, you should master both the ultrasound nerve stimulator approaches for especially in difficult cases. Our spinal is contraindicated. Use combined technique in deep blocks, obese patients, pediatric and anatomical difficulty in blocks. And these are all the regional anesthesia, if you are using it as a sole anesthetic technique, is individualized. That is a site-specific anesthesia and analgesia according to the surgical requirement, considering the patient's need, and adhere to the current guidelines for from the leading societies. ASRA is the major one. Of course, ESRA has got some guidelines there. Then ultrasound, the last word is ultrasound is always superior, is a myth. The nerve stimulator has its own role and it is useful in difficult cases. So we will see you in the next episode with another myth related to regional anesthesia. Keep connected to Anesthesia Connect. Until then, goodbye, take care, good night, my dear friends.
Imagine lying on the operation table as your surgery proceeds. You are deep asleep under the influence of anesthesia. But then you start floating above your own body and watch as a team of strangers fight to bring you back after the monitors had flatlined. Tonight, we navigate the fine but fascinating line between conscious mind and the subconscious as we go through real cases that actually challenge our knowledge on awareness under anesthesia when the brain is supposedly offline. I'm Devi Padmakumar and welcome back to the third episode of Anesthesia Chronicles, where we discuss stories that truly matter from all walks of anesthesia. Awareness under anesthesia, although rare, is not impossible. Large-scale studies such as the NAV5 project shows that awareness occurs in roughly 1 in 16,000 to 23,000 cases. As we all know, risks increases in emergency surgeries, trauma, cardiac surgeries, and obstetrics, situations where the drug doses may not be optimal in order to maintain stable physiology. So what exactly is a near-death experience? Near-death experiences are intensely vivid, often life-changing episodes reported by people who were clinically close to death or under deep anesthesia. Common features include a sensation of leaving the body, moving through a tunnel towards light, encounters with deceased relatives or spiritual figures, and a profound sense of peace and clarity. The Lancet notes that some patients report an NDE-like phenomena after unintended awareness during anesthesia, thus blurring the line between consciousness and unconsciousness. Some researchers like Bruce Greyson at the University of Virginia have proposed neuroscientific models to explain NDEs.
Most of us are taught that the mind is what the brain does, that all our thoughts, our feelings, our perceptions, our memories are all created by the brain. However, that's not the whole story, and we have hundreds and hundreds of experiences that occur during a cardiac arrest or deep anesthesia when we know the brain is not capable of functioning well enough to create complex thoughts and feelings and memories. Most near-death experiencers say that in the near-death experience, their senses were incredibly heightened, and they often report hearing sounds they'd never heard on Earth and seeing colors that they'd never seen before. And when they come back, they don't know how to describe these things because there aren't words for them to describe them.
The hypotheses include cerebral anoxia, producing tunnel vision and bright lights, temporal lobe activity, generating vivid hallucinations and life reviews, and even anesthetic drug effects of ketamine, propofol, and nitrous oxide, which can induce dissociative states resembling an NDE. Yet paradoxically, near-death experiences occur when the brain activity should be minimal, such as during deep anesthesia, a DHCA, or cardiac arrest. This contradiction fuels the ongoing debate in neuroscience and anesthesiology. So, where do we draw the line between consciousness and the subconscious? One of the most famous and controversial cases in medical history was the 1991 Pam Reynolds case. Pam Reynolds underwent neurosurgery for a large basilar artery aneurysm. To operate safely, the team had placed her in deep hypothermic circulatory arrest. Her body was cooled to around 15 degrees Celsius, blood was drained from her brain, her EEGs had become silent, her eyes were taped shut, and her ears were sealed with molded earphones, emitting clicks to test evoked brainstem potentials. Her brain was as close to being offline. But after the operation, Pam reported something astonishing. She described the surgical saw accurately. She also described the head fixation device used during the craniotomy.
I began to feel a sensation, a tingling at the top of my head, and I all of a sudden popped out the top of my head.
Pam says that her near-death experience continues as she feels herself drawn away from the operating room towards a brilliant white light.
When I was out of the body, I had a distinct physical sensation, a pulling from the abdominal region just above the belly button, and I saw a tiny, tiny little pinpoint of light, as if it were way far away. And I went toward the light, and as I began to get closer and closer and closer, I started to discern my grandmother. I started to see her, and she came to me, along with an uncle.
But as in so many other near-death experiences, Pam is stopped before she can enter the light.
I wanted to go into the light, but they wouldn't allow me to do that. There was a time when I realized it was time to return to the body.
The case remains debated. Some point to possible overlaps and others to coincidences. Others argue that the details are too specific to be dismissed. One of the boldest scientific attempts to study the conscious mind and beyond was the AWARE trial. AWARE, that stands for Awareness During Resuscitation, were led by Dr. Sam Parnia, an intensive care physician known for studying what the brain and mind can do during cardiac arrest. Parnia asked a radical question. If patients report memories when their heart has stopped, could we record what the brain is doing at the moment? And could we test whether their perceptions are accurate? As part of the AWARE-1 trials, after surviving a cardiac arrest, patients were interviewed. Some described the classic near-death features of the tunnel, the bright lights and the sense of peace. But a smaller number reported specific details of resuscitation, machine sounds, voices, timing of defibrillatory shocks, details which could actually be correlated. And this suggested that brain activity may not cease completely or immediately after a cardiac arrest as once was believed. The AWARE-2 studies took things further and the results were remarkable. During CPR, even when the blood flow was critically low, some patients showed brief bursts of organized brain activity, patterns associated with conscious processing. Not full consciousness, not normal awareness, but not flatline either. According to Sam Parnia, consciousness may not vanish instantly. It may fade in stages, and during those stages, the mind may generate structured experiences that the patients later remember. So whether you interpret this through neuroscience, through philosophy, or through mystery, the implications are profound. For clinicians, NDEs raise important questions. How do we monitor depth of anesthesia to prevent such awareness? What do these experiences teach us about consciousness itself? Should anesthesiologists be prepared to discuss NDEs with patients who report them? As anesthesiologists, our work sits at the edge of consciousness. Patients hand us their awareness and trust, the most precious things they have, to bring them back safely. What can you do as an anesthesiologist? Master the science. Know your physiology, your airway, your drugs, and your backup plans. Be the calmest mind in the operating room when things get unpredictable. But also master the human side. Speak with kindness, reassure with confidence. Remember that for your patients, this isn't just another routine case. So when your patient shares a strange dream or an extraordinary anesthesia experience that they had, do not dismiss them. Listen to them, validate their feelings, because these moments matter more than we realize. Never forget that you're not just giving anesthesia. You're actually guiding a person through the boundaries of consciousness and then bringing them back. Do it with precision, do it with vigilance, and do it with heart. So if you'd like to explore more, the BBC documentary, The Day I Died, covers the Pam Reynolds case with interviews and surgical context. The Aware 1 and 2 papers are also available online. Links will be in the description box below. Thank you once again for watching this episode of the Anesthesia Chronicles. So if you have enjoyed our episode so far, please tell us which topic you'd like us to explore next. Until then, stay curious, stay safe, and I'll see you in the next episode. Thank you.
Thank you, Dr. Devi, for that nice presentation in the Anesthetic Chronicles. Now we'll go to the ISA Kahoot quiz. So those who have not yet joined can join the Kahoot quiz using the pin 4244570. Those who are not familiar with Kahoot, you can go to either Kahoot app or Kahoot site and just type in the pin. So you will be getting around 30 seconds for each questions, and the faster you answer, the more points you get. So we'll be having 3 winners after this quiz. So I'll wait for those who want to join, and we'll start the Kahoot quiz now. So in this quiz, I have sprinkled a few clues to the answers in the pictures that is given along with the questions, in some questions. So if you are not sure about the answers, please do have a look at the questions that come along with the pictures that come along with the questions and try to make them. So that's the answer from that. So we shall move to the Kahoot quiz. Those who have, the pin is 4244570. We'll start. So this is the ASA Kerala Kahoot quiz. There is a cash prize for the winner and e-certificates for the runners-up also. So you can still join the Kahoot by keep giving the pin. So last week's 15th November quiz winner was Dr. Guru Santya S. From Kumaran Medical Center, Coimbatore, and who has won the cash prize and the e-certificate. Dr. Guru Santya Sharavana Perumal. Congratulations, Dr. Guru Santya. Then the first runner-up was Dr. Virendra from Christian Institute of Health Sciences and Research, Dimapur, Nagaland. And congratulations, Dr. Virendra Pradap Maurya. And our second runner-up was Dr. Kailash Mohan K. from Baby Memorial Hospital, Kozhikode. And congrats to Dr. Kailash Mohan K. Now we'll go to the Kahoot quiz, ISA Kerala Kahoot quiz. First question: what does his score indicates increased perioperative cardiovascular risk following surgery? 4 options are less than 34, less than 58, more than 34, and more than 58. You can choose either one of the answers that you feel is correct. And we have got around 9 more seconds to complete it. And we have around 5 people who have got the correct answer. And we'll go to the next question. So the scoreboard, the leading is Guru with SRUT in the second place and Nila in the third place. And we'll go to the second question. Per ASRA guidelines, after therapeutic dose of low molecular weight heparin, the minimum saved interval before removal of epidural catheter is option A, 4 to 6 hours. The next option is 12 hours. The third option is 24 hours. And the fourth option is 72 hours. So you can click on the answers which you feel is correct. We have got around 8 more seconds to answer. Okay, it is 24 hours because it is a therapeutic dose. The prophylactic dose is 12 hours, and for unfractionated heparin is 4 to 6 hours. So we'll go to the next question, and most of the answers are the correct one. So we'll go to the third question. Because we have it checked scoreboard, we still Guru is leading with SRUT in the second place and Sun in the third place. So things can move around fast. So hope everybody be sharp. The next question. When a patient's family act with the clinician to deliberately hide a serious diagnosis from the patient, it is called paternalism, shared decision making, conspiracy, or collusion. The answer is also the name of a New York bestseller book written by Luke Harding, which speaks about how Russia helped Trump win the White House, which was quite a controversial book. So I have sprinkled a bit of clue for those who have some doubts regarding the question. And we have 2 more seconds. And so the answer is collusion. And most of the people have got it right. And we have a look at the scoreboard. Still, Guru is leading. There is no much changes in the scoreboard. So we'll go to the next question. Who published the Drug and Alcohol Abuse Among Anesthetists Guidance on Identification and Management? So the options are WFSA, AAGBI, ASA, and RCOA. So I have given the document head, first page of the document. You can see a logo there or a coat of arms there. And if you can identify by that also, you can arrive at the answer. So the question is, who published the guideline, Drug and Alcohol Abuse Among Anesthetists Guidance on Identification and Management? And the answer is AAGBI, whose logo is given there. And quite a few have got it right. And we'll have a look at the scoreboard. Yes, we have some movement there. Nila had surged ahead into third place, and SRUT has maintained the second place, and Guru is still leading the scoreboard. So the next question. Indication of pre-op echocardiography as per the 2024 AHA guideline for perioperative cardiovascular management for non-cardiac surgery. The options are age more than 65 years, mild murmur, which is asymptomatic, it is routine before all major surgeries, or new onset dyspnea, which is the indication for pre-operative echocardiography as per 2024 AHA guideline for perioperative cardiovascular management for non-cardiac surgeries. We have 3 more seconds, and yes, most of the answers are in the correct place. Indication is a new onset dyspnea. We don't use the age-based guidelines for as per the 2024 guidelines, AHA guidelines, and asymptomatic murmurs also are not an indication. So just before we go on to the final scoreboard, coming up on the December 6, 2025 AnaesthesiaCONNECT, we have a case presentation, diabetes and anesthesia, and we also have a critical appraisal of a journal article in the journal club, which will be held on December 6 at 7 p.m. So in the description in the YouTube, I have the link for the paper which will be discussed in the journal club is given. Everybody please have a look at the paper so that adequate time can be gotten for that critical appraisal. So the case person, the diabetes case presentation, diabetes and anesthesia case presentation will be, moderators will be Dr. Gobu Maradi, senior consultant from the Department of Anesthesia in the Anantapuri Hospital and Research Institute, Trivandrum, and Dr. Bharti Vadhwa, he's the director and professor, Department of Anesthesia, Maulana Asad Medical College, New Delhi, and Dr. Shruti RS will present the case. And for the critical appraisal of a journal article, the moderator will be Dr. Lakshmi Kumar, Professor and Head, Department of Anesthesiology and Critical Care, Amrita Hospital, Kochi. And the presenters will be Dr. Mahatma Goya and Nalluri Achyuta Krishna Sri. So please find the link to download the journal article in the description below. Download it and read it early. So we'll have a look at the leaderboard final. Sorry, this is the original article which will be coming up on the December 6, 2025. Thoracic spinal anesthesia, an effective alternative to general anesthesia in breast surgeries, a randomized non-blinded study. The link to download this is given in the description. Everybody please do download it and go through it before the discussion on December 6th. So the 15th November ISA Kerala Kahoot quiz winner is on third place we have SRUT, so, and second place we have Nila, and first prize we have Guru. Congratulations, Guru, for that achievement. We also have two runner-up. There will be a cash prize for the winner, and e-certificates will be provided for all the podium finishes. So I say Kerala Connect for giving me the opportunity to conduct this quiz. I myself is Dr. Arjune. I'm a faculty from Department of Anesthesiology, Government Medical College, Kozhikode. So thank you.
Thank you, Dr. Arjun, for conducting the quiz in a very lively manner and selecting precision questions. I think the audience also must have enjoyed the quiz as much as you enjoyed preparing it for us. Thank you very much, Dr. Arjun. So
thank you.
Moving ahead to the vote of thanks part, I think it takes immense pleasure to thank all the lead faculty and teams who contributed to this magazine edition of Anesthesia Connect by ISA Kerala. Dr. Ashu Mathai from Believers Church Medical College, Dr. Sajeesh Gopalan, Dr. Baburaj C, and Dr. Devi Patnakumar. I think the audience response has been excellent. This is only the third episode of their series. We look forward to seeing you in the further episodes as well. And I think everybody enjoyed the ISA Kerala Kahoot quiz as well. Thank you, Dr. Arjun, for conducting this. I think from the audience point of view, you should make sure that you put your nickname when you join the quiz as first 4 letters of your alphabet, followed by your mobile number. Then only we'll be able to trace you. This is just to bring our appreciation to you. Okay, so next episode onwards, we'll be more stricter on this. And to make a note of it, our WhatsApp group is active, Anesthesia Connect by ASA Kerala. The joining link, the invitation link is given in the description of this video in YouTube as well as Facebook. So first week of December, we are going to have a case presentation as well as Journal Club, as Dr. Arjun announced. The Journal Club article is already announced and declared, and you can all access the article, read up and come, because Journal Club is not about presenting the article, it's about critical appraisal. So we look forward to your company on the webinar edition on the first Saturdays and the magazine edition on the remaining Saturdays. May I have our ISA President, Dr. Binil's closing remarks for that before we close for the day.
Thank you, Dr. Sanish. It was an excellent episode by all the 4 speakers. They have done their work wonderful, especially Dr. Devi Padmagar. It was an excellent session from her, episode from her. Then Dr. Baburaj, again Dr. Sajesh Ji. He is giving every week new clues to everyone. So he is the master. We can learn from the master itself. And of course, Dr. Ashwin Mathai and team, they have done excellent work. So thank you all. And of course, last but not the least, Dr. Arjun. Excellent quiz time from Dr. Arjun. You engaged everyone. I think more than 15 members joined, or more than 20 members joined for the quiz. Excellent work done by you. So thank you, and thank you all. Good night. See you all next week, same time, same days, next Saturday. Good night.